Dr. Elling, based on the clinical presentation of portopulmonary hypertension, how does one screen for this and ultimately correctly diagnose it?
Okay, very important question. We screen for this condition in patients who are at risk, patients with portal hypertension. They don't necessarily have to be dyspneic, fatigue, swelling, or have chest pain. They may have those symptoms, but many patients, and this was seen in a large series of patients, the majority weren't even short of breath. So we can't use just our clinical assessment to determine if they need to be screened. A cirrhotic with portal hypertension should be screened for the presence of portal pulmonary hypertension when you're seeing them in clinic and when they're being evaluated for liver transplant. And just one echo that's normal doesn't get them off the hook. You have to keep following them over time because they could develop it over time when they're awaiting transplant or being followed in your clinic. So our best screening tool is a transthoracic echocardiogram. That looks at pressures and it looks at how the right heart is functioning. We have a cutoff that should trigger us to go forward with right heart catheterization, and we can look at both pressures or we could look at the TR jet velocity. If we're going with pressures, the European Respiratory Society says trigger at 50. A systolic pressure in the pulmonary system of 50 should trigger you to go on to have a right heart catheterization. If you're looking just at TR jet velocity, if you're less than 2.8 and you have no concerning symptoms, we think you're probably low risk for the development or the presence of portopulmonary hypertension. Those patients that have a TR jet velocity 2.9 or higher are people we need to screen. And if you look at this next slide, it has a very nice diagram of how we evaluate patients with portopulmonary hypertension and what should be our triggers to go on to the next step. You'll see here, we have our patients with portal hypertension. We go on to get a echocardiogram, and we want that echocardiogram to specifically ask to look at the right ventricle and to look at the pulmonary pressures and the TR jet velocity so we can take all of that information into consideration. If the TR jet velocity, as I mentioned earlier, is 2.8 or less, and we don't have any worrisome symptoms, we're done for now. We can wait, watch that person, and we'll probably rescreen them again in 6 to 12 months. Now, if that TR jet velocity is elevated, or the patient is symptomatic, they have dyspnea, they're lightheaded, they have any RV abnormalities on that echocardiogram, we go on to do a heart catheterization. Work's not done there though. With that heart catheterization, we have to figure out what their hemodynamic profile is. We may be lucky. That TR jet may have been overestimated, and they may have a normal heart catheterization and their mean pressure is less than 25, and then they go into the no pulmonary hypertension group. Anybody with a mean greater than 25 is diagnosed with pulmonary hypertension. Not necessarily all portopulmonary hypertension. We have to figure out which group they land in. So there's 3 different hemodynamic profiles we frequently encounter. We frequently encounter those people with too much fluid in their body. Their wedge is high, and that's driving the whole abnormality. And those people will have a normal PVR. Now, if they have just high flow because of the high flow state seen in liver disease, those individuals will have a high mean PA pressure, but a normal pulmonary vascular resistance. If we do land and we find a patient with true portopulmonary hypertension, their mean pressure will be more than 25, their wedge will be in the normal range, and their vascular resistance will be high. Those are the people we need to treat with specific therapy. Now, I want to point out one very important group of patients. Those patients that have a mean that's less than 25, maybe it's 21, their wedge is in the normal range, maybe 10, but their vascular resistance is not absolutely normal. It's in that 2 to 3 range. Those people need to be watched extremely carefully. Those patients may be in the early stage of disease, and you don't want to say, yes, you're good to go, and they don't get a liver transplant for 12 to 18 months. In that time, they may have progressed significantly. So those people you want to be re-echoing and then possibly repeating your right heart catheterization to see if they meet criteria for treatment.
So is there a definitive diagnosis for portopulmonary hypertension?
Definitive is a mean pulmonary artery pressure of 25 or more, a wedge pressure of 15 or less, and when you calculate the pulmonary vascular resistance, it's more than 240 dynes or 3 Woods units. So that is our diagnostic requirement in terms of hemodynamics. Now, in the setting of portal hypertension, you must also have high portal pressures. So that's the caveat and the important thing about patients with liver disease. So you could have a patient with autoimmune hepatitis that has no portal hypertension, and you've proven it by imaging, evaluation, and hemodynamic monitoring, and you do have pulmonary arterial hypertension from their underlying autoimmune disease. So you could have both things in a patient that is affected by liver disease. But when you have portal hypertension and you have pulmonary arterial hypertension, until proven otherwise, it's portal pulmonary hypertension. Does that make sense?
It does.
Okay, great. Thank you.
Thank you.
It's very tricky.